Hey guys, this lecture is going to be over chapter 43, which will be nursing care of the male patients with genital urinary disorders or reproductive disorders. All right, so let me see if I can adjust the screen a little bit. There we go. So this is going to be, this lecture is going to be on the prostate disorders specifically, and the big ones we're going to talk about in this lecture are going to be prostatitis, benign prostatic hyperplasia or BPH, and prostate cancer. I'm having difficulty with my screen. Okay, so the first disorder is prostatitis, and this is where you have an inflammation of the prostate gland. So etiologically, this could be bacterial, which could be acute, or it could be chronic flare-ups. It could be chronic prostatitis or chronic pelvic pain syndrome. And then it could also be asymptomatic inflammatory prostatitis. So signs and symptoms that our patients dealing with prostatitis will be pain at the area, urgency, frequency, dysuria, urinary retention, fever, chills. And so if you're looking at this list of symptoms here, it actually is pretty similar to what we would see for a UTI. So when we do have an individual that we have these symptoms with, we want to rule out a UTI in addition to the prostatitis. So diagnosis for prostatitis, like I said, we're going to do a urine exam or urinalysis with a urine culture to make sure that we don't have a UTI in addition to the prostatitis. But to rule out prostatitis, this is where they're going to do a digital rectal exam or a DRE. And so that is done by the provider examining the prostate through the rectum and basically palpating for any type of inflammation. So interventions for this, because we're dealing with bacterial in nature as a lot of the cause, antibiotics. We will also give some anti-inflammatory agents, stool softeners because we want to make it easier to go. Sitz baths, those are kind of warm water baths that they a lot of times will prescribe for women after they've given birth, but it's also very beneficial for a man with prostatitis. They can do prostatic massage. We can look at some dietary changes such as avoiding alcohol and spicy foods. And then last resort would be surgically to remove part of the prostate gland or, completely remove it altogether if we are continually having chronic flare-ups. Your nursing diagnoses for prostatitis, the worst complication that we'd be dealing with here would be urinary retention. So we want to make sure that we address any urinary retention issues either with, straight catheterization, and make sure that, this enlargement of the prostate gland is not causing so many urinary issues that we've got urinary retention, UTI type issues. So that is going to be your priority with prostatitis, is addressing those urinary issues. Other things we could go with would be a knowledge deficit related to the cause, the treatment, and prevention of prostatitis, acute pain, and anxiety. We have to address anxiety when we're dealing with a male in terms of any type of inflammation or any type of issue with the genital urinary region. All right, the next thing we're going to talk about in this lecture is going to be benign prostatic hyperplasia or BPH. And this is a little different for prostatitis because prostatitis was an inflammation of the prostate gland, where this one is an increase in the number of cells. And that's what hyperplasia is you have too many cells. Which will cause similar symptoms to what we saw with prostatitis. But again, they are two completely different things. So signs and symptoms of this are going to be very similar to what we just talked about: urinary retention, dribbling. So we talk about, anytime we're dealing with the prostate, when it gets enlarged or it is too large, we have issues initiating a stream and stopping a stream. So dribbling would be one of those side effects. Nocturia, where we're, having urinary issues at nighttime, dysuria, and urgency. And again, these are very similar sounding to a urinary tract infection. So again, we want to make sure that we are ruling out any urinary complications with this. So diagnosis with this, we're going to do that digital rectal exam so we can access the prostate gland. We want to look at our kidney functions, so a BUN, creatinine, PSA. This is the prostate-specific antigen. This is a basic lab draw that we can do to look for any elevation, and that elevation in that PSA is going to be indicative that we have some type of prostatic issue. And so a PSA will give me an indication of, do we have BPH going on, or do we need to take it a step further and rule out prostate cancer? So the PSA is kind of a screening tool to see if we've got some type of prostate issue going on, or is it something that we need to be more concerned about, like cancer. We could do some urodynamic flow studies, especially with that urinary retention. You can do a transrectal ultrasound to get direct visualization of the prostate gland, and cystoscopy, which would be a scope into the bladder and really examine the bladder from the internal perspective. So for your therapeutic interventions, we're going to do symptom control. So for the urinary retention, we're looking at catheterization. We want to make sure that we increase fluids to, flush the kidneys, make sure that we have adequate urine output. And we a lot of times will do antibiotics because, well, anytime we have urinary retention, we have stasis of urine, which predisposes our individuals to UTIs. So an antibiotic will often be used either. So intervention-wise, this is something called watchful waiting. So we're going to kind of look at it and make sure that the patient doesn't get any worse. Medication-wise, we may start them on some alpha-adrenergic antagonists. We can sometimes do some hormone blockers because, we're worried about testosterone. So anytime you see an individual, like a male, on birth control, for example, it's usually because we're trying to block the male hormones. Procedure-wise, there is the TUMT, which is a transurethral microwave therapy. That's a typo. It should be TUNA, which will be a transurethral needle ablation. And then there's, again, surgical options that we can go in and completely remove the prostate gland if necessary. Now, the procedure that is most often used for the prostate gland is something called a transurethral resection of the prostate, and this is known as a TURP procedure. And basically what you're doing is you're going to use a resectoscope, insert it into the urethra, and that very long scope will, and you can see from the picture, will actually go to the prostate gland and chip away overgrown tissue, okay? And then the chips are flushed out with irrigation. So usually what that they set up here is a continuous bladder irrigation or a CBI setup. It is important to know that the tissue can grow back. And so this could be something that they'll have to do a couple times, okay? It may not be where it's only a singular isolated event. If the tissue grows back, then they can always go back in and chip away at that tissue again. And then here is a picture from your book on prostatectomies. And so this is when they go in and actually remove the prostate gland itself. And then there's 3 approaches they can take to this. So the picture on the far left, that is a suprapubic prostatectomy where they're going over the suprapubic bone and accessing the prostate gland that way. You have a retropubic prostatectomy where they'll go right beneath the symphysis pubis bone. And then you also have a perineal prostatectomy, which is actually very rare because, as you can see, the insertion site down there, the perineal area is not ideal for surgical entry because of the risk of contamination in that area. So that will be the least likely route utilized. So for any type of prostate surgery, pre-op nursing diagnoses, we're looking at impaired urinary elimination because that's usually the #1 reason why we're doing prostate surgeries. And knowledge deficit, there's a lot of teaching that needs to go in for an individual undergoing prostate surgery. Postoperatively, again, we're always worried about bleeding with any post-op patient, so risk for bleeding. We want to make sure that we monitor urine output, so we want to do the amount, but we also want to inspect it for any evidence of bleeding. We're going to encourage fluid so that we can flush those kidneys, flush the chipped away pieces of the prostate gland, and we want to teach the patient to avoid constipation, so we want to make sure that we increase the fluids, limit or do adequate, appropriate activity. Stool softeners is necessary. We want the patient to avoid any heavy lifting or any overly strenuous exercise. So you would be real careful with somebody if they said that they were push mowing their lawn, for example. Okay, so that's not something we would really want them to do in that immediate post-op period. And we're also concerned about any additional bleeding. So we want to teach our patient to avoid aspirin and NSAIDs if they are able to. After prostate surgery, one of the things that you have to be monitoring for is acute pain related to a bladder spasm. So we're going to be monitoring that pain. And remember, like I said, a lot of times these patients are going to have CBI set up or continuous bladder irrigation. And sometimes with that, they get clots. So you may have to irrigate the catheter as ordered. We will administer analgesics. You can have a drug class called antispasmodics, which actually reduces the amount of bladder spasms. And we want to teach our patient relaxation and deep breathing so that they can, breathe through the pain or breathe through the spasm when it's actually happening. After prostate surgeries, it's not uncommon for them to have urge urinary incontinence. So we will teach our male patients Kegel exercises where they tighten and relax to build up that muscle so that they have improved continence. We can offer condom catheter or urinary pads. We want to encourage to continue the fluids, and that's a big misconception a lot of people have when they do have, incontinence, is they feel like they shouldn't drink fluids, and that's certainly not the case. We want to make sure that we encourage them so that they don't get a fluid volume deficit issue. And anytime there is prolonged incontinence, that's something we want to make sure that the patient will discuss with their urologist or their primary doctor, because it could be that there is some other underlying condition that needs to be addressed. So for our knowledge deficit, we're going to teach to avoid for about 6 weeks any heavy lifting. We don't want them taking the stairs. We don't really want them driving a motor vehicle. We want them to avoid any type of strenuous exercise, any straining. We want them to avoid sexual activity and aspirin and NSAIDs for about 6 weeks. They a lot of times will be sent home with a catheter with a leg bag. So we want to teach our patients proper catheter care about cleanliness and signs and symptoms to report, such as signs and symptoms of a UTI. And we also want them to inspect their urine. So we want them to report any increase in bleeding. And then here is a picture of a bladder irrigation setup. And so what you're going to use is, a Foley catheter. You're going to have very large bags of fluid. So usually 3,000 milliliters of fluid. And what it does, it just goes in, flushes the bladder out. Okay, so it will flush away any of those chipped away pieces. The other thing that is great for the CBI is it also applies pressure inside the area, so that it can actually help with any hemorrhage, because the pressure of the balloon a lot of times will stop any hemorrhage that they have. But because we're flushing with so much fluid, it's really important that you pay very, very close attention to the drainage bag and empty it as necessary, because we certainly don't want this bag getting too full. Anxiety related to sexual function is a very common fear that men have after prostate surgery. So we want to explain to our patients that retrograde ejaculation might be something that they may experience. So the ejaculate can actually go backwards instead of forwards. And that is something that you do want to caution your patients about. We do want the patients to feel comfortable about talking with the physician, especially if any erectile dysfunction occurs. Okay, and that's a misconception a lot of men have, is that when they have prostate surgery, is that they will have erectile dysfunction afterwards. And that's not necessarily the case. So we do want our patients to make sure that they are addressing these issues with their physician. All right, for prostate cancer, this is a cancer that usually afflicts elderly gentlemen, usually over the age of 65. Other risk factors for prostate cancer include high testosterone, a high-fat diet, family history, and certain occupational exposures. And with prostate cancer, this is actually the most common cancer of American men. So this is something that you will see quite a bit of in your nursing career. So signs and symptoms, in the early stages, it's very, very rare to catch it on. There's usually not any symptoms, but as it starts progressing, then you're going to start seeing some of those symptoms that we talked about, like urinary obstruction, maybe hematuria or bloody urine, urinary retention issues. So again, it sounds very similar to what we've been talking about. Oops, sorry about that. There we go. Oops, sorry about that. It sounds very similar to, our BPH, and so that's where that prostate-specific antigen, that PSA blood test is very, very helpful in determining if we have a prostate issue in the first place, and if we rule out BPH, then prostate cancer is the next thing that we need to be worried about. As it advances and starts spreading, we're looking at bone pain, we're looking at anemia, we'll look at weakness, unexplained weight loss, but this is a very slow growing cancer. So this is not like this is something that takes over, very, very quickly. This one usually takes a while for it to advance. So diagnosis for this, you'll do that digital rectal exam, and upon inspection, the provider will usually find a hard lump over the prostate gland. We're going to do that prostate-specific antigen. There are other types of tests that they can do called a PAP, which is not the same test that they do for females. Not as commonly used, but we prefer the PSA. But for any type of cancer, we want to make sure that we biopsy. So we want to do a transurethral ultrasound with a biopsy, because that's the only way to definitively diagnose cancer. And then if we're concerned about metastasis, we can do a bone scan and make sure that we don't have any metastasis to the neighboring bones. Your surgical or your therapeutic interventions for prostate cancer. So if you catch it early on, they can do some testosterone suppressing medications like Lupron or Zoladex. Those are common medications that they could give. For your later stages, that's where they'll do that TURP procedure or an open prostatectomy and radiation to kind of shrink down the tumor. If we're dealing with metastatic, now we're looking at more aggressive surgery. So it may spread to the testes, which in that case we would have to do an orchiectomy. You may have to give estrogen therapy we will have to give estrogen therapy if we remove the testes. We may be looking at chemotherapy, more advanced radiation, and a prostatectomy on top of these things. So it is important that we do catch this and we don't wait till the metastatic advancement. We want to catch it early if we can, so we can treat with medications or where we can do something relatively simple like a TURP procedure. So it is important that men, as they age, that they are getting that digital rectal exam yearly and that they are monitoring any signs and symptoms suspicious of cancer.